The role of allogeneic stem cell transplant in CLL has always been controversial. This is a disease in which most patients are elderly, they're frail with comorbidities, but there have been identified criteria for the use of allogeneic stem cell transplant that were published in 2007. Those criteria identify patients who are sufficiently high risk to merit the use of an allogeneic stem cell transplant. Those same criteria that we use for transplant are also the criteria that we now have approval for agents like Ibrutinib and now Idelalisib, and very shortly will likely have also for venetoclax. The issue then is, in the era of having these newer agents available, how does that change the algorithm of where a transplant fits in? Well, the short answer is the data is demonstrating that the number of transplants that are being offered for CLL is falling off quite markedly. That's because the availability of these agents has meant that many patients who previously would have gone to transplant are going on to these therapies. That's because of the safety profile, the duration of responses that we're seeing. I think there was a period of time where people were using these agents as a bridge to transplant, getting patients into a better remission and then transplanting the patients. As we've become more comfortable that the data has emerged that patients are having longer remissions, the question then comes, well, who has sufficiently high-risk disease on a novel agent to merit transplantation? Some data is beginning to emerge of who are the patients who may fail therapies. Clearly, those patients who are intolerant to the treatment or who fail the treatment would have an allogeneic stem cell transplant. Those patients often have a very narrow window of when they relapse, so when transplant would no longer be an option. So the real challenge right now is to identify who those patients are and when we should do it. Now that we have, of course, not just one or two, but potentially soon 3 agents available where we'd be able to sequence and look at these agents in combination, it's becoming even more difficult to determine exactly who should have a transplant in CLL. So it's a constantly shifting sands that are occurring right at the moment where we're looking for data to emerge to help us identify who are the patients and when transplant should be offered. The last issue, of course, would be where would these therapies play a role in post-transplant? So we could look at potentially making a transplant safer with more T-cell depletions or something to make the morbidity of the transplant safer and get better disease control by considering these novel agents in a post-transplant setting. That's still a clinical trial question we don't have the answer for.